Totally.
Good afternoon, everyone. My name is Dan Mitchell, Chair of the PDAB Board of Maryland, here for today's meeting, July 28th. We have a quorum with board present. Everyone's present. Thank you. We're going to deal with approval of minutes in 3 different minutes. We normally don't have this many. So the May 19 open meeting minutes were submitted and sent to everyone. Do I have a motion for approval?
So moved.
Second.
Motion and second by Jerry and Stephen. Any changes? All those in favor, aye.
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 Opposed? Approved. Now, next, we're going to take the closed meeting minutes that were sent to you. I know Andy sent them earlier today. I think everyone got them. Again, I'll entertain a motion in a second.
So moved.
Jerry,
Second.
Stephen. Any changes? All those in favor, aye.
Aye.
Ayes have it. And lastly, our June 23rd meeting, regular minutes, a motion for approval.
So moved.
Jerry,
Second.
Stephen, second. Any changes or corrections? All those in favor, aye.
Aye.
Approved. Okay. Next, we're going to move to item 3, and I think Christina is on virtual with us. Do we have any open for public comment, Christina?
Hi, Van. Yes, we received 4 written comments. Those were shared with the board and they will be posted on the website. I just want to let everyone know, due to the global Microsoft SharePoint disruption, we've been able to post those comments yet, but we will post them as soon as we have access back to our website. We have 3 requests for oral public comment today. The public commenters will have 1 minute and 30 seconds to speak. We ask that you state your name, the organization, agency, employer, or other entity with which you are affiliated, if any, or whether you are a consumer, and the agenda item that you would like to address. And then you can start your comment. Anna, I just want to confirm that we have a 90-second timer for our commenters.
You can say yes.
Yes.
When she gets the timer set, Derek Flowers will be first.
It's set up, Christina. We're good.
Okay. All right. Mr. Flowers, you may begin.
Thank you. Good afternoon. I'm Derek Flowers with the Value Coalition, a network of patient, provider, and caregiver organizations. Because clinician input should be at the forefront of decisions impacting patient health, we commissioned a new white paper reflecting feedback from specialists in 4 states, including Maryland, who treat the very patients affected by this process. And their concerns are urgent. In the limited time allowed, I'll relay some of the findings. First, specialists are concerned that PDABs haven't sought their input. 93% said there hasn't been sufficient knowledge sharing between boards and healthcare providers. Second, this exclusion puts health outcomes at risk. When considering therapeutic alternatives, 56% of endocrinologists, the specialists who often prescribe the drugs under review today, said they wouldn't even switch patients to another drug in the same class. 2/3 of endocrinologists voiced concern that PDABs will impact treatment availability and clinical choice. Third, administrative burden and patient care are top of mind. All specialists surveyed, 100%, worried that PDAB decisions would increase administrative work and reduce time spent with patients. 96% expressed concern that UPLs will lead to non-medical switching, forcing patients off effective medications to meet cost targets. These findings should give the board pause. Clinicians, the people who know best how medications work, who understand what happens when treatment plans are disrupted, they're raising serious alarms. And this is a pivotal moment. As the board makes today's decisions and looks ahead, we urge you to engage clinicians more meaningfully, evaluate real-world consequences of UPLs, and most importantly, consider non-UPL strategies that can lower costs while improving health outcomes. Maryland has a chance to lead, but please do it in a way that puts patients and those who care for them at the center. Thank you very much.
Thank you. Dr. Harry Duwanter, you are next. I hope I pronounced that correctly.
You were really close, and close enough. Good afternoon. I am Dr. Harry Gawanter, a pediatrician and pediatric rheumatologist, and a board member of the Let My Doctors Decide Action Network, an organization of patient advocates clinicians, and other healthcare leaders. I share Derek's concerns about your lack of sufficient input from patients, clinicians, and other frontline stakeholders. Remedying this deficit is essential before you recommend any actions. Any report that is going to develop good policy needs to have comprehensive and diverse feedback before it is recommended. I especially urge the board to recognize and prioritize the concept that therapeutic alternatives are not therapeutic equivalents. When we consider making substitutions or therapeutic changes, we only think about equivalents, not alternatives. For policymakers to unilaterally designate certain medications as therapeutic alternatives could fundamentally disrupt the patient-clinician relationship and decision-making. You are, in fact, practicing medicine by requiring non-medical switching. Patients with chronic conditions require continuity of care for good outcomes. You must widen your lenses. Drug affordability policies must focus on what patients actually pay, not inflated list prices. And you must consider the entire drug supply ecosystem, and including the role of payers and PBMs. I urge you to prioritize patient being over arbitrary. Thank you.
Thank you. And lastly, we have George Huntley.
Yes, good afternoon, and thank you for your time. Chair Mitchell and members of the board, I appreciate the opportunity to speak. My name is George Huntley. I'm a patient living with type 1 diabetes, and I'm the CEO of the Diabetes Patient Advocacy Coalition and a Baltimore native. As you consider preliminary affordability determinations for Farxiga and Jardiance, we urge you to ensure that access to essential diabetes treatments is not unintentionally compromised. Farxiga and Jardiance have transformed care for people with type 2 diabetes, especially those at risk of heart failure or kidney disease. These medications are not optional for many patients. They prevent hospitalizations, they delay complications, they improve lives. Any action, especially a UPL that affects how these drugs are priced, could have unintended harmful effects by restricting formulary access managed through pharmacy benefit managers. Such policies could result in restricted formularies, increased out-of-pocket costs, or prior authorization hurdles, forcing patients to switch from effective therapies due to pricing mechanics, not medical need. We ask the board to consider non-UPL alternatives, like encouraging policymakers to require insurers and PBMs to pass on negotiated savings to patients at the pharmacy counter. This approach can cut the cost to patients in half, as rebates are roughly half of the branded cost drug on average. Policymakers should also be encouraged to delink PBM compensation from drug list prices, removing perverse incentives that contribute to price inflation. Finally, we ask that the patient voice remain central to this process. We appreciate the opportunity to speak today, and we stand ready to work with you. Thank you for your time.
Thank you. Thank you all. This concludes the public comment for today.
Great, thank you very much. Thanks to the three folks that came forward. Thanks, Christina. Andy, we'll go into the presentation for the overview on the cost review study process. And just so everyone knows, today we will be going into closed session for two different times. The first one will be as it is on the agenda for Farxiga. The second, Jardiance, and we will come back in between. So it could be a long day, so just wanted everyone to know what was coming up. Andy?
Great. Thank you, Mr. Chair, and thank you, members of the board. We have a series of presentations today, and the first presentation is just going to be an overview of the cost review study process. I'm going to keep it quick because it's a presentation you've heard from me probably half a dozen times now, but I did just want to give you and the public an overview of what to expect in today's meeting. Right now on the agenda, we do have the board conducting the kind of first step in the cost review study process for both Farxiga and Jardiance. So we just wanted to talk through what that looks like. So we're going to give an overview of the cost review study process itself, which we're working through today. And then if the board takes any action based on the cost review study, then the next steps, which is our policy review process. I can give you kind of an overview and immediate next steps for the policy review process. So what we're going through today and what we've been going through for, I guess, close to a year now, is the cost review study process. So the board, we'll go over, so the final step of the cost review study process, or the steps up to this point, include getting to a preliminary determination. So in today's meeting, we expect to provide an overview of the cost review study process and policy review process, which we're doing now, provide an analysis and overview of the data that you've received as part of the dossier, and also note the different factors that you're allowed to consider. Then we're going to go into closed session to discuss confidential, trade secret, and proprietary information and get advice from counsel. And then ultimately, you will deliberate on whether or not there's an affordability challenge based on the information provided. And the outcome of that process may be a preliminary determination on an affordability challenge. So you can say that the drugs may cause make the preliminary determination that the drugs may cause an affordability challenge or high out-of-pocket costs for patients, or you can say that you don't identify any affordability challenges. And then depending on that step, then you would go into the policy review process. So as mentioned on our agenda, excuse me. Need to make sure I'm staying on the right slides, excuse me. Okay, so as we mentioned on the agenda today are two drugs, Farxiga and Jardiance. They are two every drug that you are reviewing for your cost review study process needs to be independently reviewed and considered. And ultimately what you're determining today is whether the use of the prescription drug product has led or will lead to an affordability challenges to the state healthcare system or high out-of-pocket costs for patients. And whether that use has led to, the use that's led to affordability challenges or high out-of-pocket costs is consistent with labeling approved by the FDA or standard medical practice. So these are the terms, this is what's going to ultimately be kind of articulated. And then the way you will do this is by identifying the circumstances under which the prescription drug has or will lead to an affordability challenge to the state healthcare system or the high out-of-pocket costs for patients under Section A1 of this regulation. So that is the outcome that can potentially happen today. Again, you'll kind of want to go through each of these elements and just make your preliminary determinations. Let's see. So again, the factors that you're allowed to consider. So the staff may assemble data and analyses for the board's consideration. That is the dossier that has before you and has been published on the website. The final version was posted last week with supporting exhibits. We did post an updated version. I'll go over this during the presentation. We basically found a typo in a table title, so we just fixed that so there were no substantive changes. The board may consider different factors, including data, information, analysis, specified in the regulations. So if you have any questions on what you're allowed to consider, please do ask throughout this process, but ultimately you want to stay within the limitations of the dossier, what's presented in the dossier, and what you're allowed to consider as part of your regulations. Sorry. Okay, so then again, your preliminary determination. So you've updated your regulations so that the board can make a preliminary determination of whether the use of the prescription drug has led or will lead to affordability challenge for the state healthcare system or high out-of-pocket costs for patients. And it's important to note that this is a preliminary determination, so it's non-final and subject to revision or modification. This again is kind of a milestone, but not a final step as you continue your process on determining whether or not there's work that the board needs to make these drugs affordable. So the next steps immediately after the preliminary determination is if the board does make a preliminary determination that there's high out-of-pocket costs or affordability challenges to the state healthcare system, then you go into your policy. You have to do a draft report. So there is going to be, after this, the staff will review, draft a report based on the deliberations and determinations of the board today. That draft will be published for public comment, and you will ultimately need to finalize that report, and that will be one of the final actions of the board, is finalizing this cost review study that articulates your findings as part of the process. This again will be published as a draft document that the public will be able to provide comment on. The next element is You've seen this graphic before. As part of your preliminary determination, the first thing you can do is say that you did not identify an affordability challenge to the state healthcare system or high out-of-pocket costs for patients. So the next action is for us to finalize the report articulating that. So that is one pathway. The second one is if you do determine that the drug causes an affordability challenge or high out-of-pocket cost to patients, then the next step is for staff to identify the drivers of those circumstances. So as part of this process, you should be telling us that the drug causes, articulating the circumstance that shows the drug is causing the affordability challenge. Then it's up to the staff to identify the drivers or market failures or reasons that those circumstances exist, and then recommend policies that can address those circumstances. So as you heard in our public comments today, that is not necessarily limited to any specific policy. I think we're looking at basically everything that a state can do to make those prescription drugs more affordable. So the next step, take any determinations you make today, preliminary determinations, then find the drivers or the why of why those circumstances exist, and then go into the how of how you would go about fixing that through state policy. You've seen this before, but we have, so the red at the bottom is the report. So we like to pull that out just because it adds some clutter. We have steps for if you are looking at non-UPL policies. So ultimately, the board will let us know which policies you would like to move forward with in a subsequent board meeting. For non-UPL policies, well, for both, we go into information gathering. So we try to gather the information that we need to understand the drivers and then identify potential policy recommendations. You have non-UPL policies that you can recommend. For each of those, we basically do background research, get public input, and ultimately would be proposing a resolution from the board on what those policies would be and how they would be implemented. And then the top line is the UPL processes. So because your statute actually has authority for setting UPLs, we do have a very robust process for moving forward through the upper payment limit process. Again, it starts with information gathering. Then the staff proposes the methodologies or frameworks. Then the board approves the framework, then we post the numbers themselves based on that framework and the math and all the assumptions that go into that. That all goes out for public comment. Any changes that come based on public comment get posted again. So ultimately, the public will be able to comment on the final version, and then that would come before the board. And then ultimately, anything you do around upper payment limits would be published through regulation. So you would do a proposed regulation, then a final regulation. So that's just, again, giving you an overview. Depending on what happens today, we will, again, just briefly go over the immediate next steps after this meeting. But again, this just gives an overview of what the policy review process is. So anything you do today, again, is a milestone, but certainly not the end or final step of this process. So again, the immediate next step is going to be based on the available information, working on the drivers and market conditions that cause the affordability challenge, and identifying policies. And then a lot of this is going to be based on information gathering. So the immediate first step after this would be to gather any additional information that the board feels like you need to make your decisions around the drivers, identifying the drivers and understanding the policies that can address those. So that's, so I already went over this. Here's kind of the information we would include for any policies that are not a UPL. And then if we move forward with the UPL, there's the broader policy process that I had articulated. Again, we make a recommendation on the drivers, the extent to which the UPL may address them, and then we have the process for publishing the framework, then publishing the actual numbers, and then bring it before the board for a final, to be implemented by regulation. Again, you will hear this multiple times if the board moves forward with any of these steps. So with that, I just wanted to give you an overview. So for today, we are at kind of that intermediate step in the cost review study process. And during today's meeting, the board may make a preliminary determination for either of the two drugs that are on the agenda today. So any questions on that? If not, I can move into specific drug. Go ahead, Dr. Anderson.
Jerry has a question.
Yeah, so we have access to confidential data.
Correct.
When you write the report, not what we're doing today, I know how we're doing it today, but when you write the report, how are you going to be able to handle confidential data for the public? I mean, are you just going to have data that's redacted? Is that approach?
Yes, so there is a redaction policy, but I would also just emphasize that the information that's submitted through the RFI, which is where a lot of the confidential proprietary information comes, is extremely protected information. So we
Correct.
just will be very careful with anything that is derived from that that goes into the final report. But we also have proprietary data that we receive from different databases, and all of that would be redacted. So everything that would be published would be carefully redacted in terms of the proprietary data we receive from databases.
Okay, anything else before we get started? Okay. Cost review study on Farxiga.
Great. So if you look at the agenda, the first part of this section is to go through the dossier, the publicly posted dossier. So we're going to go through each of the different factors that are available to you and that the board can consider. I would be happy to answer any questions. So if you have any clarifying questions based on the publicly available information that we're going through, feel free to ask that at this point. I think we would probably want to save any deliberations for the end after you're able to talk through the confidential proprietary information. So planning to just go through this, answer any questions that the boards have, and then we can go into closed session for the confidential proprietary information. So for Farxiga, we had a number of different iterations. This dossier in particular, we posted draft versions, received intermediate feedback from the board, and kind of let that document evolve over time. The first time it was posted for a meeting was in the May 19th meeting. Again, kind of showing the board the template that we were working with and what we were planning to include in the dossier, received feedback from the board, and ultimately posted a draft dossier of both this and the other drug under review on June 18th. And we posted that so that we could have a public comment period. I think it was a maybe 14-day public comment period. So comments were due on July 3rd. Those comments have been posted on the website, and we published the final version of the dossier last 2 weeks ago on July 18th. Yes. On July 18th. The comments that we received, so we had minor changes to the dossier based on the comments that were received. There were a number, so for the draft dossier itself, we received 6 comments for Farxiga. And the general themes included technical changes, processes, and comments on the processes and deadlines, a lot of discussion around the upper payment limits concerned. We did receive some support about upper payment limits, but also a lot of opposition and concerns with upper payment limits. We also did get some comments just on general metrics, data evaluations, and methodology concerns, also affordability concerns and payment design. The idea that many of the affordability concerns are kind of plan design issues, and then also a lot of comments and questions on therapeutic alternative interchangeability, and you heard some of those in the public comments that we received today. All those comments were provided to the board and posted on the website, so the board has reviewed those comments. It did result in a couple changes to the document. So staff posted the final version on July 18th, and if you did compare it to the version that was posted in June, it was a lot of general formatting changes and copy editing, so there were kind of a significant number of just formatting things, but limited substantive changes. One commenter noted that the federal government links on the original draft had all kind of changed and gone dormant. So we found the new links and corrected those links. That was very helpful, so appreciate that public comment. And then also for Farxiga, there was a very good comment on authorized generics. So per our statute, the board is, the authorized generics are not included in any kind of, they're separate from the cost review. They're not included in the product that is under the cost review study. And we've seen a lot of questions about the NDCs that we've had. And we originally were using an FDA website to verify the classification of authorized generics. And our Farxiga was not originally showing up on that list, but after we received this comment, we did go across additional FDA databases and were able to verify that some of the NDCs that were on the original list were authorized generics. So those have since been pulled from the initial NDC list, and I'll go over this during the presentation. But the board is still allowed to consider them under section 8.4, I believe. So the information is still available for the board for consideration, but those NDCs are not under the cost review study at this time. So we very much appreciate the feedback and flagging that issue for us. So going into the dossier structure, We have a background section, and we'll go through each of these. We have a clinical information section. Section 3 is on regulatory approval and market context. Section 4 is the utilization data based on the all-payer claims database. We then go into Section 5, which is pricing information and rebates. Section 6 looks at the different therapeutic alternatives, cost comparisons, and health economics and outcomes research. Section 7 looks at cost sharing and insurance benefit design. And then Section 8 is other information. This is the list of exhibits. So we do have, I think, 6 exhibits at this point. The list is one of the last pages in the dossier for folks that are looking for it. The first exhibit is a series of pricing histories. So this is available to the board. A lot of these pricing histories, I guess you can see it for the publicly available prices, but WAC is redacted from the public-facing version, NAWP. The next exhibit is here, let me pull this up, sorry. The next exhibit is Exhibit 2, which is information that is available to board members but is not publicly posted, and this is the RFI information. So again, it includes non-public, trade secret, confidential, and proprietary information. So again, this is available to the board but will not be publicly posted. Exhibit 3 is our therapeutics alternative pricing list. The public-facing version doesn't include some of the proprietary metrics that we license through different databases, but the board does have access to those. Exhibit 4 is the therapeutic alternatives and the medical claims database. So we do a lot of utilization information on the therapeutic alternatives. And then finally, we have Exhibit 5, which is a summary of cost effectiveness analyses and comparative effectiveness research. Those studies are listed, and we try to briefly summarize in the different we make a table of the key points that the board has asked for in previous meetings. And then finally, in Exhibit 6, the board is allowed to consider any public comment that has been received up to this process. So that has been available to the board in your packet as well. So with that, I'm going to briefly go through the dossier, if that's okay. Board members, please feel free to stop me with any questions or clarifications, but I'll try to go through this relatively quickly. So. The background section is just the overall background. You can see that there's a number of different NDCs in this list, and this is one of the things that we received comments on. There's about 6 NDCs that are the most relevant for analysis, so kind of 6 NDCs that are currently active. But we get our list of NDCs from RxNorm, which is a nationally recognized comprehensive database. And so up to this point, we've been overly inclusive on NDCs. So as the board and the public will see in a lot of the utilization data, a lot of these NDCs show up with no utilization because they're either inactive or were never ultimately used. But for the purposes of our study, we did think it was important to capture every NDC that we think could be linked to the drug, but there's probably about 6 that are the most relevant and where we see most of the data. We have a very, I think, useful and readable section on the clinical information. So in Table 2 on slide, sorry. So in Section 2, you can see that Farxiga has these 3 indications. One is as an adjunct to diet and exercise to improve glycemic control in adults and pediatric patients under 10 years old with type 2 diabetes mellitus. The second is to reduce risk of hospitalization for heart failure in adults with type 2 diabetes mellitus and either established cardiovascular disease or multiple cardiovascular risk factors. The third one is to reduce the risk of cardiovascular death and hospitalization for heart failure and urgent heart failure visits in adults with heart failure. And then the last one is to reduce the risk of sustained EGFR decline and end-stage kidney disease and cardiovascular death and hospitalization for patients with heart failure with chronic disease at risk of progression. So these are all kind of copied and pasted from the FDA approval list. We had a team that did a clinical analysis of the different clinical guidelines as well as a comparison and evaluation to the FDA indications. And I would recommend that all folks read that section. I think is very accessible and readable. But the key takeaways that we had for the board today is that the SGLT2s are a preferred drug class for the treatment of type 2 diabetes. They're considered first line therapies given the overall safety, so low risk of hypoglycemia, and then also effectiveness in lowering blood sugar, and it also has chronic kidney disease, cardiovascular disease, and heart failure benefits and protections. The GLP-1 agonists have demonstrated similar outcomes and are an alternative first-line therapy. And then metformin is also considered a first-line therapy with effectiveness in lowering blood sugar, low hypoglycemia, and then potential cardiovascular benefits, but has not demonstrated the same benefits in heart failure or kidney disease. Jardiance, Farxiga, and Invokana are all the preferred choices in the class for medical professionals, given their benefits for heart failure, cardiovascular disease, and chronic kidney disease, though just echoing the comments that you heard during the public comment today, that a lot of this is, there's an element of clinical decision-making and collaboration between the patient and their prescriber in selecting the right choice. In terms of heart failure, the SGLT2s, specifically Jardiance, Farxiga, and Impefa are recommended to be taken for all symptomatic heart failure patients. And then in place in therapy for chronic kidney disease, it's to lower the risk of kidney disease progression and acute kidney injury and improve cardiovascular outcomes. SGLT2s are recommended by major guidelines for adult CKD patients with diabetes mellitus, heart failure, and or albuminuria, and suggested for all adult chronic kidney disease patients with an EGFR of 20 to 45. So I know there's some clinical elements to this. I think the key takeaway here is that these are important drugs that are first-line therapies and have an important place in therapy, especially with patients with diabetes and other comorbidities. And we do have a note that all spending utilization data is consistent with the labeling approved by the FDA or standard medical practice. So everything that you're seeing within the dossier is within those parameters. All right, so the next few slides just give you an overview of the prevalence, incidence, disease severity, cost and financial impact of the disease, morbidity and mortality for each of the conditions. I'm going to briefly, in fact, I'll probably just go very briefly through these sections, just noting that all of these disease states have a substantial impact on patients and the state as a whole. So all are has very important indications, and again has an important role in treating each of these indications. I would emphasize or recommend that the board and public kind of go through the clinical section, just understanding the impact of these diseases. Section 6 or Section 3. Oh my gosh, I'm sorry, I've been going through the wrong slides. Okay, so. This section is the place in clinical care that I was mentioning. Excuse me, sorry about that. And then section 2.2 is the disease burden. So we provide it for type 2 diabetes, heart failure, chronic kidney disease, and those are the key indications. The next section in the dossier is section 3, which is a regulatory approval and market context. I think the key takeaways here is we just articulated the different, when it comes to market, so it was first approved January 8th in 2014 and received a series of subsequent indications, kind of expanding the role of the drug. So this just gives the timeline for each of the different indications that were approved. Section 3.2 is whether or not the drug is in shortage, and Farxiga is not currently in shortage. Section 3 is the analysis of the market context of the prescription drug, including the product's life cycle management, patent management, regulatory exclusivities, and product hopping. So that's what the title of the factor is. For the purposes of the dossier, we mainly focus on the different patents that are in there. So I did include the table of the patents that's in the dossier. I think the one key takeaway is that one of the major patents, and we did see this, I think, in comment letters as well, is like one of the kind of main patents is set to expire in 2026. So that just does mean that at some point there will be generic competition, but I don't think there's any specific timeline on when the generics would be coming to market. For section 4, we go through the different utilization metrics. So factor 4.1 is the total gross spending in the state for prescription drug products under review, the total number of patients in the state, and then also the drug product and percentage of overall spending. We calculate this for commercial, state and local government, and Medicaid, and then Medicare. As you know, the first three are going to be relevant for our work. So the second one is state and local government, is one that both comment letters and then also board members have expressed interest in. So you can just note that these key findings here. And then it does kind of note the difference from the commercial spend as well. The last column shows the percentage of the spend, of the total gross spend. So if you are trying to identify what percentage these drugs make up in the total spend of each of these different categories, so for example, in the commercial sector, you would add up the percentages across these NDCs. So in this case, it looks like about 1% of total prescription commercial gross spending is spent on this drug. And then you can break that down by each of these different sectors. There's state and local government, Medicaid, and Medicare. 4.2, it provides the change in total gross spending over time and the utilization for a prescription drug product in the state between the two most recent calendar years. This is just supposed to provide trend information to board members on whether or not utilization is going up and also whether or not costs to the for different markets is going up. So you can see these trends here. And we do that for each of the different sectors. We break it down by the different markets, commercial, state and local government, Medicaid and Medicare. We do that for all of our utilization data. 4.3 is the impact of utilization and spending on public budgets and comparison of the spending on different relevant benchmarks. For the purposes of our initial cost review studies, we exclusively just looked at the metric above. So percentage of overall spend for the prescription drug for the specific market. I think in future dossiers, we can look at different kinds of budgets that we may want to compare against. But for the purposes of this dossier, we are just looking at, or we just provided the percentage total spend. So I'm going back up, you can see here. In this last column, it's like percentage of the total spend for each of these markets. So, you know, drug divided by total spend for that market. Again, in future cost review studies, we can look at different metrics and we may work with the board to identify different percentages of budgets that you may want to look at.
Excuse me.
Yeah, go ahead.
Yeah, just for clarification, so everybody's on the same page. You're talking about just the state employee and retiree market in Maryland?
What's represented in what you have here is state and local government. So it's pulled from the all-payer claims database, right. Which includes state, yeah, and then each of the counties and municipalities. Right. So that's all pulled from the APCD, but we divide it by market. So you get that percentage for the commercial market, for the state, local, county, municipal government market, Medicare and Medicaid. The reason, so you can see staff wasn't able to assess the impact on other public budgets. So we did explore looking at total state budget, total healthcare budget, but without additional guidance, we didn't find kind of meaningful metrics there. So we stuck just with the one above, which was percentage of prescription drug spend. Okay. Yeah. All right, so moving on to section 5, let's see. Okay, so this is pricing information and rebates. For 5.1, we went through the different pricing metrics. You've heard a number of times of what each of these different pricing metrics means. So Exhibit 1 reflected the changing in the price history for each of these metrics. So that's just pricing history over time that's published, but the public-facing version, again, redacts the WAC and AWP. In this file, you can see the different metrics. So, sorry, I'm working across two different documents here. But you can see that we've published the publicly available metrics in the public version of the dossier. So if you zoom in here, you can see that we have NADAC, the state actual acquisition cost, the federal fee schedule. So all of those are available in the public version. The board also has the version that has the WAC and the AWP. Section 5.2 is information estimating the manufacturer net price and net sales amounts of the prescription drug product under review. These are, again, redacted as proprietary information. Anything that's in the dossier is based on databases that have been licensed. So that's an important thing to note is everything that is in the tables and has been redacted is based on 2 different data sets that we have available to us, but we're not allowed to disclose publicly. In 5.3, we have the information estimating the manufacturer net price and net sales on the drug product under review. In this section, we did note that there is a publicly available number, so we did kind of adjust that based on WAC. So just wanted to note that we have that in section 5.3. And then also we have a methodology to try to capture other price concessions, rebates, and discounts. Again, that's all available to the board, but redacted in the dossier that's publicly available. 5.4 is price concessions, discounts, and rebates that the manufacturer is provided to or expected to provide to the prescription drug product under review to each PBM operating in the state, expressed as a number and as a percentage of the WAC. This information was submitted through the RFI, so they are available to the board, but not available as public exhibits to the dossier. Same thing with 5.5, which is information supplied by the manufacturer, explaining the relationship between the price of the drug and the cost of development and the therapeutic benefits of the drug, or information that's otherwise pertinent to the manufacturer's pricing decisions. Again, that's included in the RFI submission. If we move on to section 6, this is the therapeutic alternatives, cost comparisons, and health economics outcomes and research. So we did compare the therapeutic alternatives by WAC, AWP, NADAC, state acquisition cost, state actual acquisition cost, ASP, and the federal service schedule, or I think that's what that is, for each of the therapeutic alternatives. As you heard from the public comment that we've received and also some of the written public comment, there is a lot of feedback on what is an appropriate therapeutic alternative. Again, the way that our original list was created was that we looked at therapies that fit on the same tier of the standard of care. So basically going through the clinical guidelines, what drugs can be used at each stage of the clinical care or each stage of therapy. I think diabetes is a pretty robust, there's a lot of treatments that are available. So I think one thing to emphasize, and I know we've said this a number of times, is stating that a drug is a therapeutic alternative is not at all a endorsement saying that they are therapeutically equivalent or anything like that. It's just saying that they can fit within the same kind of stage of care. The other reason that the list had as many elements as it did is the way our regulations are structured is if you want to be able to consider any pricing information from those drugs, they need to be included in this. So if you want to look at any comparative effectiveness research or cost effectiveness research, those drugs need to be listed as therapeutic alternatives. So I don't think there's any strong judgments in this work on where this is, or if this therapy is better or worse than other therapies, but we did try to provide the different studies that can let the board members kind of think about that element. So long-winded way of saying, in Exhibit 3, we do have basically all the therapeutic alternatives that the board has approved and all the different pricing information for those therapeutic alternatives. That includes WAC and AWP, which are available to the board but not the public, NADAC, SAC, ASP, and the federal schedule. One thing to note is just that I think we identified 5 drugs that are in the same class, so just noting that those are all available in the data that's been provided to the board. And then in factor 6.2, the average price concessions, discounts, or rebates So the same thing, that's all available in Exhibit 3. That means that this was based on a proprietary database that we had. We were able to calculate estimated concessions, discounts, and rebates based on the database that we were using for that. Exhibit 4 includes the utilization costs and out-of-pocket costs for therapeutic alternatives. Again, it's a pretty wide-ranging list just based on the list of therapeutic alternatives that were approved. So that's all available in the Excel document that was provided to the board. And then we did also try to collect the incremental costs associated with the product, including financial impacts to health, medical or social services that can be quantified or compared. So basically for this, we did a lit review on different cost effectiveness analyses. The lit review that we did, we included the search criteria. I think it was a specific database that we're using for the cost effectiveness analyses, and then for the comparative effectiveness, we used an existing list, I think that was used by Medicare. So we kind of pulled from that list of studies. So all the study names are available in the table that was provided to you and I think published online. All the studies I think are also available to the board members, and then we also did summarize the key elements that the board asked for, I think in our May 19th meeting in those tables. So please feel free to review. Go ahead.
Point of, just to note, since we're
Yeah.
talking about that list, so the dossier makes reference to a specific list of studies.
Yep.
With a reference.
Yep.
And the reference takes you to a website that is in fact CMS's website, but doesn't provide a list readily. So I think it'll be easier for the public as we go forward, that if we're going to provide these links, they're going right to the list of studies that we're referencing in the dossier.
Okay.
So that individuals are not having to jump around the website to find it.
Yeah, so I can tell you our thinking on the reason we managed it the way we did. The CMS list, so we were looking specifically for comparative effectiveness research. So that's what that CMS list was for. So we basically reviewed, I think they maybe have 176 studies, including the original like random controlled trials, just like baseline clinical information. What we were looking for is when it was being compared to other therapies, which often is not a randomized controlled trial. So what we looked at was a subset of the studies that were provided by Medicare. So we reviewed everything that was listed by Medicare. There was a lot of like primary research only on the drug itself that was not included for comparative effectiveness purposes. And our list that we provide, I think in Exhibit 5B, is a subset of the list. So the reason we included that is if anyone wants to go back and see the original list of 176 studies. But then the only ones that we did a careful analysis for and provided a summary on was the subset that's listed in Exhibit 5B. I think it's 5B. Yeah, so we do, I think we can think through the best way to manage that.
Well, that's why I was looking for the list, is because we used a subset, because I
Right.
wanted to see what was not included
Exactly.
in our
Okay,
list.
that's fair.
But the original list is hard to find
Yeah.
with the link. So
Okay.
it's just so that we are pointing ourselves to
Sure.
where that list is posted on the website.
Okay, yeah, thank you. Okay, so I'm on 6.4. So just, I think if you're trying to get any general takeaways, we did include some just general findings. So on the cost effectiveness side, I think, if I had any takeaways, and this is kind of done at the class level, there are actually very few studies that compare within the class. So a lot of the comparative effectiveness and cost effectiveness research was actually for the class as a whole. So I think there was some comparison between the two, so I'll go over that in subsequent ones. But I think at a very high level, the SGLT2s are effective for reducing cardiovascular risk for patients in diabetes. For heart failure, there's similar additional benefits in the subgroups with and without diabetes, so the subgroup doesn't matter. So I'll just say that the SGLT2s are important for patients with heart failure. For chronic kidney disease, there's similar benefits to those with and without diabetes. So again, an effective disease for those patients. For diabetes, there's benefits in all groups, but the incremental benefits are more notable for patients with CV risk, heart failure, and kidney disease. And then this was also kind of outlined in the clinical information section, but compared to the GLP-1s can be more effective on diabetes outcomes in general, but, and also the GLP-1s may have additional benefits over SGLT2s in patients with cardiovascular risk, but the SGLT2s may have additional benefits over the SGLT1s for patients with heart failure and kidney disease. So again, the main takeaway here is that the SGLT2s definitely do have an important place in therapy for patients, especially certain subgroups with comorbidities. So all to say that these are, this drug does have an important place in therapy and should be a first-line therapy for many patients. So section 6.5, same thing. We have two separate sets of analysis. One is the cost effectiveness analyses, and then there's the comparative effectiveness research. So just looking across those, in factor 6.5, we have the information derived from health economics and outcomes research that may address the effectiveness of the prescription drug product in treating the conditions for which it's prescribed, or improving patient health, quality of life, or overall health outcomes, and the effectiveness of the prescription drug product compared with therapeutic alternatives or no treatment. So again, just a description of what the comparative effectiveness research is supposed to represent. In 6.6, we go over the, just check if there's any generic products that are available. So we can just note that Farxiga is not a generic drug product, and I already mentioned the issue around authorized generics. 6.7 basically looks at therapeutically equivalent products, so that functionally a generic. And for Farxiga, there are no therapeutically equivalent drug products approved by the FDA under other applications. And then we have two more sections. Section 7 is the cost sharing and insurance benefit design. In 7.1, that's the estimated impact of the patient access resulting from the cost of the prescription drug relative to insurance benefit design. Go ahead.
For clarification on this factor.
Yep.
So estimated impact on patient access, and this may be a question for you or Michelle, but how we're to interpret this, sort of the language of it, when I read it, it sounds to me like we're wanting to understand a causal relationship. So then I'm taking that differently when I look at analyses, or I can read it like an association. How are they related to each other?
I can take a first pass, and then Michelle can respond. I would say we are looking for I think the best we can do is look for the association, but you may be able to say a strong association versus, like it's unclear what the data will say, so we explore the data and see what we can see. And I think in some cases, you may be able to see that there is a causal relationship, but otherwise, like what the indicator we're looking for is like association.
But we're not bound to a causal with the
that's right.
regulatory,
Yeah.
okay.
Yeah.
Thank you, I just wanted to clarify.
It's a good question, though. Like,
Thank
that's
you.
probably something we would want to discuss is like, what does it mean? Yeah. But I think both are on the table. Yep. So you'll remember that we did a pretty in-depth analysis, and this still remains a pretty large part of our paper. We go through the analysis that we did. And so we basically, what we tried to look at is if there was a relationship between average co-pays and coinsurance and the number of prescription people use in a year. That was kind of the metric, the best metric that we could come up with. And basically, we found that any impact is small. When we presented that to you in the May 19th meeting, the board asked that we also do a broader general lit review. So that's where this additional information comes from. So we were able to find a couple studies that basically found that without controlling for other factors, we did see that about 77% of patients with low co-payments had more than 80% of their days covered. In comparison, 72% of those with medium and 72% of those with high had 80% coverage. So you can see, again, limited impact, but there does seem to be probably an association. I'm not sure if you can call it causal. And then one of the studies found, and we don't have an explanation for it, one of the studies found that increased copays were associated with more prescription days covered. So again, this was not specific to the drug under review, but this is what we found in our general literature review. So we can talk through any potential implications for that. But our analysis based on the data from the state found a very small impact. In section 7.2, This is the expected or current dollar value of specific patient access programs that are supported by the manufacturer for the drug product under review. We did find that there were a number of patient access programs, and I believe these programs were also referenced in different public comments that came in. But our research is based on all just publicly available information, such as the Farxiga's savings card. We weren't able to find the overall value of the patient assistance program, or if there's any kind of scope to the program. But we have kind of seen general feedback that it's an important program for helping patients access their drugs in an affordable way. Section 7.3 looks at average patient copays and cost sharings for the prescription drug in the state. Again, we look across the different markets. So this is for the commercial. We identify the average deductibles, average copays, and coinsurance. So we go through each of these for each of the different markets. So this is for I guess Medicare, oh no, this is state and local government. You can also see the average cost share for the different patients for state and local government, for each of the different market sectors for commercial, state and local government, and Medicare. We didn't include Medicaid because it's a nominal flat cost, $1 to $3 copays for Medicaid. And then also we included the mean, median, and 90th percentile for out-of-pocket costs per patients compared to state incomes. So we do just include each of the different mean, medians, and 90th percentiles for each of the different markets. Let's see. In 7.6, we did actually have an interesting finding here. In the analysis we were trying to do on the medical claims database, it didn't include demographic information that we needed to do needed for the vast majority of patients, so we were unable to make conclusive assessments, but we were able to do a literature review. So we've included the summary of that literature. I've highlighted some key findings here. I think one of the main takeaways, and this I think is important, is that it looks like a number of patients that should be on SGLT2s are not taking the drugs, especially based on certain demographic criteria. So it basically looks like there's underutilization of SGLT2s in certain patient populations, especially the Medicaid population, which we didn't have the chance to kind of dive into that, but that was something that kind of stood out to us, that the Medicaid percentages look much lower than the general public when we didn't see anything that would otherwise explain it based on demographics or population. So that was kind of an important finding that we wanted to note. All right, so going through the last few factors, in 7.7, we calculated the cost of the health plan based on patient access. We basically, for this one, we do a graph table where we apply just the FDA-based indication and then multiply that times the WAC, so you can see what that will be. All the other information that we provide you is utilization-based, so this basically just confirms that everything you've seen in all the utilization data falls in line with clinical use and FDA indicated use. So that table is more of a validation than anything else. Section 8, we have other information. So this is included all the input from the public. So we did have a number of different comment periods where folks were allowed to provide public, and all those comments have been kind of compiled and provided to the board for your feedback. We did receive good feedback throughout the entire process, so it was good for the board to re-examine some of those comments. And then we did not receive any, so for factor 8.2, we look at the impact on state and federal regulatory compliance related to the prescription drug. We didn't identify any issues with this drug, so this was a very brief section. For 8.3, input from state and local government entities and entity contractors such as health plans and health administrators. We did not receive input from these entities at this time, so we'll continue to work with them for future cost reviews. 8.4, information and analyses submitted under 04 this chapter. All of that was contained in Exhibit 2 of the dossier. This information is all confidential and proprietary information that's available to the board, but will not be available to the public to protect that information. And then that's the last element that we have. So that just goes through everything in the dossier. I know the board members have reviewed all the documents and reviewed the dossier itself, but did just want to go through each of the factors that are available for you to consider. So with that, I'm happy to answer any information or answer any questions you have on the publicly available information that I discussed today.
Chair is happy to open it up for questions before we go in private session. Jerry?
So I had a question about slide 39. I know I've gone through all of these. First of all, you did a great job both of presenting it, but also just assembling an amazing amount of information. So I want to compliment you on how much you've done. But there is one set of numbers on here that I just want to make sure I understand. And that is, if I look under slide 39, Fartsiga, and I want to compare the state average cost, which is $67.51, to the Medicare negotiated price of $21.42. Are these apples and apples, or is there something different between these two? Because this is a significant difference, and I just want to understand if it's, you know, a real difference or there is something that would explain it.
The better table to look at to explain this would be,
But I mean, that's a 3-to-1 difference in, you know, what Medicare pays as a result of negotiation and what the state pays. I mean, that's a huge, huge difference. And I just want to make sure that's a valid difference.
it is a difference in metrics. So fair price, I'm looking at the table that we have it in, just so folks can reference it in the.
Zaid has his hand up.
Okay, Zaid, did you want to respond?
So my understanding is you're trying to understand what the SAC is versus Medicare?
No.
I know what the SAC is, and I know what the Medicare negotiated prices is. I want to make sure that they are, in fact, apples and apples.
Sure. So
okay,
the SAC is equivalent to a state level survey like the NADAC. It is
Yes.
intended to identify the pharmacy reimbursement that Medicaid may pay. So they do their own surveys, and it helps figure out the pharmacy reimbursement in Medicaid, along with NADAC. So Medicaid uses the combination of those two to reimburse pharmacies.
Is that a Medicare number or a Medicaid number?
There's a couple
Medicaid.
different, yeah, Zaid, thank you for comparing. So it sounds like with the question, so one thing I wanted to flag is that we do articulate this in table 14 in the dossier, so probably not available to the public because it's based on WAC. But we do include the MFP per unit divided by and then compare it to the WAC. So we get to see the concessions that Medicare is getting compared to the commercial sector. So that does show the board the difference in that price. So I think if you're looking for an apples to apples comparison, that's probably the best one to look at. These are publicly available numbers. And to Zaid's point, the NADAC and SAC are going to be slightly different than the wholesale acquisition cost. So there is the apples to apples comparison is slightly less, but I think the general trend that you're seeing is correct.
Yeah,
But,
I mean, I've looked at the confidential data, and I've seen that. But since the public can see this,
yes.
it's very important to make sure that we believe it's reasonably comparable. And I mean, a 3-to-1 difference is huge.
Yes, I think that's those numbers are based on what's available to you. Yes. Any other questions from the board?
Anyone else? Nice job. I think what we will do, though, for Jardians, you're basically going to give the same presentation. I think we'll not do that because it's already been out there. The public has it. The board's had it for a while. So I think we'll forego that.
Okay.
For the
I can highlight key differences.
Or you can pare it down or whatever. I mean, it's the exact same stuff.
Yep.
Actually,
Jeff?
could I go back one step?
Sure.
I had one question.
Yep.
Slide 52, factor 7.5.
Yep.
So this is the mean, median, and 90th percentile of out-of-pocket cost per patient. And it says compared to state incomes. I'm not sure what that is, but I think it just means disaggregated by different payer types.
So one way we could do this, and I'm pulling up the chart this might be a subset.
Oh, I didn't even
of the
ask my
table
question
here.
yet, but.
Oh, go ahead.
Yeah. So you're showing us at the NDC level, the distribution of out-of-pocket costs that these different entities paid for out-of-pocket for NDC. Is there any weighted version of this, like how many times this NDC got used and how many times this NDC got used, so we could calculate something like the average out-of-pocket? It just seems like in a vacuum, each row is just showing me one NDC code, and I don't know if those NDC codes are used once or if they're used 100,000 times.
Yeah, so you can do that through and we can show you how to do it. It's based on the Excel document that you receive on utilization. You can see the patient counts for each of these NDCs. So we can do weighting based on that. So it's not a specific metric that you pulled out, but it's something you can calculate based on the data that's available to you. So we do have each of these NDCs, and you have the patient count with each of these elements. So it's just for the purposes of this table, this is what we pulled in the dossier, but in the Excel documents available to you, you can easily do that.
And Joe, you can look at that in 4.2. If you go back to slide 4.2, which is like 25, 26, 27, it gives you the number of cases in each NDC.
But it might be easiest to do on the Excel document.
No, it clearly is, but
yeah.
I mean, for the public, if you wanted that number, you could calculate that number.
Okay.
Yeah, so all these data elements that you've seen in the tables today are basically subsets of that very, very large Excel document that's available to you and the public.
You good, Joe?
Yeah.
Stephen?
I'm good.
You got anything? Barry?
Maybe just one comment. I definitely want to second Jerry's comment. This is really an impressive document, 80 pages worth of content with exhibits and back-end analytics over the course of several weeks and months here. So really want to applaud the staff just in the depth of the work that was done and the scope of it. So, it's always easy to say, but we could have added this. So just one thing, because I did see we did a much better job with the inclusion-exclusion criteria for some of the lit reviews, but kind of wanted to point out, for example, slide 47, that there are sort of smaller lit reviews. This is kind of getting to the scope of the work that the staff did. There are multiple sub-lit reviews. And even for those, so on slide 47, the question that arose in my mind is why are there only 2 studies here? But I think if I understood better the inclusion-exclusion criteria, I'd have a better sense. So, and I come back to this, I keep coming back to the included studies because we were reminded that we're only to consider what's in the dossier.
Yeah.
Versus thinking outside to other studies we may be familiar with and things like that. So I think part of it is just sort of, assuring and providing that level of confidence, and that's where those criteria can come in, even for the sub-lit reviews, to make sure that those are articulated somewhere.
That's a great point. I think in future cost reviews, we can certainly articulate that. And this original round was also kind of responsive to comments that were received, so we're incrementally getting there. But yeah, I think for the next round, we can certainly do that. Yeah. Or even future cost reviews within this round.
You good? Okay. I'm going to entertain a motion for closed session to review and discuss proprietary, trade secret, confidential information concerning Farxiga under general provisions of 3-305B13 and Health General 21-2C03 and 21-2C10, and also to receive legal advice from counsel regarding the cost review study, maintain confidentiality and attorney-client privilege in closed session under the general provision articles 3-305B and 7. So can I have a motion?
So moved.
Stephen, second. Jerry. Any discussion? All those in favor, aye?
Aye.
Opposed? Ayes have it. Okay, we're going to go into closed session. Unfortunately, this is not something I really enjoy doing, but to those out there on the public, we'll be back whenever we get through our discussion, and then we will take up the rest of our meeting. So, thank you. Okay, we're back. Thank you, everyone, for your patience. We're going to have an open discussion over things that occurred in our closed session, as well as some public discussion as well. So I'll start off with anybody that wants to bring up whatever they want to bring up. Jerry, you want to start off? I'll let you start first. You're never bashful.
So one of the things that we noticed was that over time, from launch to the present, the WAC price increased substantially faster than overall inflation, which has the effect of increasing the cost to the healthcare system.
May I clarify for the record that in closed session, the board considered the data, and because of its proprietary and confidential nature, cannot discuss it in an open session, made a preliminary determination that Farxiga has created an affordability challenge, identifying two circumstances. One of the circumstances Dr. Anderson has just identified, which was that the percentage change in WAC over time is substantially larger than the percentage change in inflation. And then there was also another circumstance that was identified. For obvious reasons, the data and rationales are not to be discussed in an open meeting, and the board will be ratifying the findings in the closed session by board resolution.
That's fine with me.
Just want to clean it up a little bit there.
Okay.
And you said that there was another finding by the board, another determination by the board to be included? Yeah. Dr. Levy?
In general, I was, compelled by lots of the information that we observed in this dossier. One issue that I think sort of warrants, rising to the level of an affordability challenge is the out-of-pocket cost that patients are paying for Farxiga, depending on the payer. And we looked at the full distribution of the out-of-pocket cost and sort of like the 90th percentile of out-of-pocket cost amongst patients annually, depending on who their payer was, appeared to me to be quite high relative to what we think of as the net price, or how much individual payers are actually paying for these drugs, both nationally and in the state of Maryland. So that was my concern, and that was what I proposed as an affordability challenge that we discussed.
So the way I would say it is that the person is paying a very large percentage of the cost of the drug vis-a-vis the insurance company.
And the payer, and yes, I would concur with that.
I would agree.
So those two things will be included in the resolution.
Yes. Is there a motion for council to reduce your findings to resolution?
Well, we have other ones.
Okay.
So one that we didn't discuss in the private session, but it's public information, is that the state and local employees' percentage of total spending for Farxiga is greater than 1%. So it's a significant portion of the drug spending by the state of Maryland.
Do you have anything, Barry?
You all going to discuss it, or? the data that supports that?
I mean, Andy presented the data earlier today. So, you know, I mean, it's a fact that's in our dossier. And so I don't know what more I could say about it.
And I can put some numbers to that too, because it is striking to have a single product responsible for that percentage of the gross spend. So we looked at commercial, state and local government, of course, and Medicaid. Our dossier also includes Medicare, us looking kind of as a board at the state healthcare system, but understanding that our particular policy remit is the state and local government. The state and local government percentage of total gross spend is 0.9%. For the 10 mg NDC for Farxiga, for the 5 milligram, it's 0.2%. So there's your 1.1. And then if you include commercial, of course, and Medicaid, you are increasing that percentage contribution.
I think an interesting data point that we observed when discussing this was actually that as a proportion of Medicaid spending amongst all the different payers that we were looking at, disproportionately fewer patients, or as a function of gross spending at least, there was less utilization of Farxiga amongst Medicaid patients. I think that's an interesting finding that the board could potentially investigate further. As an appendum to these analyses and looking at the percentage of gross price, I think it is important that we acknowledge that the percentage of net spending would also be of interest for the board to look at. And I think we were not able to calculate that statistic specifically, the percent net spending of the denominator of net spending. We're doing it gross here. I think they're both valid measures to be looked at and understood in context. And I think the board should take as a general position that when we can, we want to use net price information.
I would second that. I think there's something to be said for working with those net prices. The Medicaid proportion certainly stood out when you considered the other categories consistently across both dosage forms for Farxiga that we looked at. The other piece I wanted to bring forward too is on the topic of net versus gross, is considering the rebate information that we had access to. What stood out to me is that there are missed opportunities for additional savings through the system were we to anchor to those net price rather than the list price.
And Dr. Levy, I just want to clarify for the record, when you were referring to the Medicaid spending, you're referring to the presentation that was made and the data that was available here,
yes,
not to the discussion about other subjects in the closed session. You're referring to
correct,
to
yes,
this
the
discussion.
public information.
If I can comment about the Medicaid spending, and I don't have any hard numbers to specifically say about this, but I have a suspicion that physicians who are seeing Medicaid patients have the perception that Farxiga is much too expensive, and they're going to stick with the lesser, the cheaper drugs, and not do the same treatment for their Medicaid patients as they might because they're trying to save money.
Yeah, what we noticed was that Medicaid recipients have a much lower percentage of use rates. And, that could be an affordability challenge. We're not sure why it's an affordability challenge, but it is indication that they are not getting care that commercial insurers, Medicare, and others are getting, state employees. It's a concern. We don't know why, and so it's something we need to investigate. But it is a serious concern.
Anybody else?
So one comment, I did want to bring forward regarding out-of-pocket. We're certainly looking at high out-of-pocket and then the 90th percentile is, it's always this thought about, is that a financial burden, the out-of-pocket spend for individuals? So 2 points I wanted to make about that is we do want to compare that to income levels, but we lack, I would say, disaggregated income information that would be helpful maybe in future cost reviews to have that. For example, I'd be very interested to look at this out-of-pocket vis-a-vis income by county and understand any variation. We did see some variation. There was some information in the dossier showing differences across the counties in Maryland in terms of per capita income. But really thinking about that with the out-of-pocket, because we always have this sort of 10% threshold of your income. We don't want people spending more than that on healthcare. So we have some thresholds we can go by, but we need that disaggregated income information. Then the second point around out-of-pocket I wanted to make a point about is, per regulation, we are supposed to look at out-of-pocket spend to access medications. We've chosen to focus on the sum of coinsurance, co-payments, and deductible, plus other liabilities, and have used the NCDB really nicely to that extent. But we wanted to make sure that we're clear that that is our definition of out-of-pocket. And there is a broader definition that's possible even under our regulation that we can explore in future cost reviews to include direct non-medical costs, outlays that individuals are absorbing to access medical care, such as daycare, transportation, parking. These are going to be things that are not readily available in claims data, but will be important that we as a board seek to, whether it's through surveys or other means, collect, because this is important out-of-pocket information.
Building on what Barry said, we also have to pay attention to different ethnics, minority groups, and whatever. We saw in the dossier that the literature shows differential access to minorities than to others, but we don't have that data for Maryland. So that would be an important thing in the future to take a look at.
Something I wanted to add that we haven't talked about much was I was fairly compelled by the work done, but also sort of the evidence generated in the comparative effectiveness of Farxiga relative to alternatives, and also the cost effectiveness. And sort of my review of that literature that was, put together and presented in the dossier was that Farxiga is a very effective drug. And that while it does have competitors, there are many use cases and many indications and many parts of clinical practice that, is very clear Farxiga should be getting used. And I sort of took that information, and the way that I, tried to decode are there affordability challenges because of that, and because there was, I think, quality comparative effectiveness of Farxiga, I was less interested in a lot of the work that we did about therapeutic alternatives and the pricing of therapeutic alternatives. So we haven't really discussed the pricing of therapeutic alternatives, here in this public meeting. And I wanted to acknowledge that I think part of that is because Farxiga is an effective drug. And I think that should absolutely be acknowledged. And when we're thinking about affordability and access, that's a very important component that I just want part of the public record.
I just want to say that nobody on this panel is trying to say that Farxiga is not an effective drug, and it is really almost superior in some of its treatment capabilities to metformin and some of the other older drugs. Our charge is to reduce the cost to the state and to the patients. Not saying that it's not a good drug, but we're just paying too much for it.
I, definitely can share my thoughts to sort of where I begin as a minimum kind of threshold to meet would be, is there a clinical condition need in Maryland? And I think the dossier really showed quite nicely the burden of diabetes in Maryland above average, diabetes-related deaths in Maryland above average compared to the country. So there is sort of this expressed need for our state that justifies our time here. And then to Joe's point, is the drug offering value for money? And that's also been demonstrated with the CEA work. And then when you kind of establish that, then it's a question of where do we go next with regards to affordability challenges, identifying where in the system we can bring that back, so.
All great points. Anybody have anything else that you want to bring forward?
One thing I might, let's see if my mic is on. So we had talked about co-insurance, co-payment, benefit design, and the impact on patient access. And again, complimenting the staff on the work that was done to put forward an original analysis for us in the dossier. I think that we need to continue to push on that and identify ways we feel we can comfortably draw some conclusions around benefit design and how that impacts access, because our charge is looking at the what of affordability, but we also want to be thinking about drivers and the why. And that kind of analysis can go a long way. So I just encourage our board staff along that path to continue to conduct original analyses where possible, and then with the lit reviews as well.
Great, good suggestion. Anything else? I think, if not, Michelle, you're working on my resolution. Yes. Is there anything that you need clarification at this point in time?
Yes, clarification from Dr. Anderson. When you, no, when you just identified the circumstance based on total gross spending, I wanted to confirm that that was for certain markets, including state and local governments, that exceeds 1% of total prescription drug spend. Is that correct?
Correct. Some of them is larger, but I was focused on state and local. It's also true for commercial and Medicare, but I focused on state and local.
All right, anything else? While she puts that together, Andy, do you want to give a quick administrative update?
Sure, I can give
And then we'll get the resolution done. We'll take up the resolution, vote yes or no, and then we'll take up Jardians.
Okay, perfect. Yeah, in terms of the administrative update, I would just note that we're continuing the cost review study process. I do have just a note depending on where the board lands on future next steps, but we do have a stakeholder council meeting on, I think, October 25th. The next scheduled board meeting is on September 15th. The board is continuing to prepare other dossiers, so I would expect to see, I think there's 6 total that we're working on, so the next 2 may be published for public comment before the next board meeting.
Is there a stakeholder council meeting in August?
There is, correct, on the 25th, I believe, the last Monday. Yeah.
I thought you said October.
Oh, sorry, I may have said that. I meant August 25th, excuse me.
Okay.
Yeah, and depending on the actions of the board, you can assign work to them for that meeting.
And how about a quick staff update for the board, please?
Yeah, we have 2 open pins. They've been open for 7 months now. We posted the quantitative data analyst position and received an overwhelming response, conducted interviews, and hope to offer letters shortly. The state did go into a hiring freeze as of July 1, so we are subject to that hiring freeze, but we're going through the exemption process. Since it is 20% of our staff in an essential role, we think that will go smoothly, but it has added some time. So.
And when will you hear on that?
It's a good question. We don't have a hard timeline, but we expect it to be soon. We've flagged that this is an urgent issue.
Okay.
Yep.
How about closeout?
Closeout has been successful. We can give final numbers. We came in significantly under budget, as I think we were projecting. Having those 2 pins open saved a lot of money, and then also we didn't use all of our contractual. So that builds our overall fund balance. So we have a special fund that carries over year to year. So the fact that we spend probably $300,000 less than our budget means that we are in a secure financial position moving forward.
And then lastly, but not least, what about the past 2 or 3 years of the uncollectibles? Where are we with that?
Yeah, that's a great question. So, yeah, for our fee assessment, we sent out about 1,500 invoices with the expectation that we have a target revenue of about $1,250. There's maybe 300 that we've been still working through in terms of exemptions, folks that don't qualify. But we do expect that final number to be around 1.25. The actual collected up to this point has been around 1.1, and that last kind of 200,000 or so has been folks that are non-responsive that get sent to CCU. So we have submitted that file, I think, for maybe 185 entities to CCU. So we expect that that's included in our revenue. So we do expect for our revenues to match our budget expenditures, our appropriation. So I think we are, again, in firm financial standing right now.
Okay. Jerry?
So I say this every meeting, but, you know, if we have a $300,000 surplus, not that I think that the state doesn't need the money, but you know, we're doing a lot of things here and we have a very limited staff. You know, we should entertain in future budgets to hire additional people.
We'll get our current pins filled as soon as possible, and then.
Right, but still, I think, you know, 6 or 7 could be possible, given the financials. I know we don't want to go over budget, but, you know, we can take a look at it.
Yeah, and you do bring this up for the last 5 years, but not that I'm counting. But
I said a couple of times.
there is a process. We have no control over pens. So this is not the time to ask for new pens. It's the time to keep any vacant pens that you have, which are very important to us. And also, I think where you might want us to go is, which I've talked to Andy about, is the ability to go to contract employees. So that, depending on where we end at the end of the year, might be an opportunity for us with some of the federal employees that have lost their jobs, being local to Baltimore and CMS, that we might be able to pick up some help there from that standpoint. So we are working on it. And just so you know, it's our money, not the state's. We're in a separate, we are set up, we have a separate budget number and a separate, we're not in the general fund. We are in the general fund, but not in the general fund. So those appropriators like myself that used to like to take money from MedCai and others in bad years, they really can't take ours. So I probably shouldn't have said that publicly because somebody from appropriations will try it. All right. Thanks, Andy, for the report. And let me know if I can help with the one position that's frozen. Great. Michelle?
We have a resolution, and Ms. Balich is printing it out for you to read, or I can read, whatever your preference.
You can read it right from there.
All right.
If you've got it right there.
Resolution 2025-01 of the Prescription Drug Affordability Board, Preliminary Determination Cost Review Study of Farxiga, July 28, 2025. Whereas the Prescription Drug Affordability Board is authorized to conduct a cost review study of selected prescription drug products, and whereas the board selected Farxiga for study, and whereas the board has considered the data analyses and information assembled by staff in the dossier, organized in part by regulatory factor, and whereas the board has considered the public oral and written comments received to date as part of the cost review process, and whereas the board considered, discussed, and deliberated concerning the proprietary, trade secret, and confidential information and data in closed session, and whereas the board may preliminarily determine whether use of a prescription drug product has led to an affordability challenge to the state healthcare system or high out-of-pocket costs for patients, and whereas the board may identify the circumstances under which the prescription drug product has or will lead to an affordability challenge to the state healthcare system or high out-of-pocket costs to patients, and whereas upon consideration and deliberation of the proprietary, trade secret, and confidential information in closed session, the board voted to make a preliminary determination and identified 2 circumstances relying on confidential and proprietary data under which the prescription drug product has led to an affordability challenge. And whereas the board hereby ratifies the closed session vote determination and the identified circumstances as set forth below, it is hereby resolved that the board makes a preliminary determination that use of Farxiga has created an affordability challenge for the state healthcare system, and that the use creating the affordability challenge was consistent with the labeling approved by the FDA or standard medical practices. The circumstances under which the prescription drug product has led to an affordability challenge include the percentage change in WAC over time is substantially larger than the percentage change in inflation, rate of increase in inflation, and that was in the closed session. At the 90th percentile, patient out-of-pocket cost in certain markets is disproportionate to the net cost paid by, and there's a typo, to the payers. It should just be by payers. That was also in closed session. And total gross spending for Farxiga for certain markets, especially state and local governments, exceeds 1% of total prescription drug spend for the state. That was in public session. Be it further resolved that in accordance with COMAR 14010405F2, the board's preliminary determination is non-final and subject to revision and modification, and any circumstance is a sufficient and independent basis for the preliminary affordability challenge determination. Be it further resolved that the executive director and staff are authorized, directed, and empowered to draft a cost review study report in accordance with this resolution and the regulations to be published as a draft for public comment, subject to a final determination and approval of a final report. And then there is a certification by you as the chair.
Okay, so I'm going to move the resolution. Is there a second? Second. Second by Jerry. And I'm going to do a roll call on this. Jerry? Agree? Bill?
Agreed.
Barry?
Agree.
Stephen?
Agree.
The chair votes for. Okay. Thank you, Michelle. We are now going to have Andy give us a brief, since everyone has received this already, and it's very similar to the Farxiga on Jardiance. And Andy, I think you took my book, didn't you?
I did. It's over here.
I'm good. I'm good.
You go ahead and start.
Thank you. As the board chair mentioned, it's all of the same sections and factors, so I will be able to go through this presentation much more quickly. So the second drug under review is, I'm going down to Farxiga, or sorry, Jardiance. All right, so the next drug, so again, the board has received the dossier, has carefully reviewed all factors and issues. We received 6 comment letters, all with the same general themes. The primary changes we made were that we, so same thing, formatting and copying, copy editing. We updated the government website links, and then also in the clinical information, the comment letter and emphasized the importance of Jardiance in a specific comorbidity. So we added additional information on cardiovascular comorbidities in diabetes specifically. So it's a comorbidity of diabetes. So that is added to the clinical section of Jardiance based on the public comments that we received. So same thing, we have the same 8 sections, same exhibits, and here's the NDCs under review for Jardiance. Same thing, it's an overly inclusive list, so the subset of NDCs that are currently active is much smaller, and you see that in your utilization tables. In section 2.1, again, I would emphasize going through the indications. So this does have a special role in patients with cardiovascular disease. So the 4 indications as an adjunct to diet and exercise to improve glycemic control in adults and pediatric patients aged 10 and older with type 2 diabetes, to reduce the risk of hospitalization for heart failure in adults with type 2 diabetes and either an established cardiovascular disease or multiple cardiovascular risk factors, to reduce the risk of cardiovascular death, hospitalization for heart failure and urgent heart failure in adults with heart failure, and then also to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular disease, and hospitalization for patients with chronic kidney disease at risk of progression. Again, Jardiance does have an extremely important part in the clinical continuum of care. It is extremely effective for patients with diabetes. Also has some important cardiovascular protection. So you do see a lot of utilization of the drug, and then also important in terms of heart failure, and then patients with kidney disease. So again, very important place in therapy as a first-line therapy, especially with patients with certain comorbidities. I'll just go through it. It has a lot of the same general epidemiology of the disease states themselves. Again, we did add some information on cardiovascular comorbidities for patients with diabetes. So that is reflected in this and in the dossier. Came to market in 2014, and you can see the different indications that were approved over time. No major changes there. August 2014 is when it came to market, and then it has the indications as outlined here. Going on to 3.2, not in shortage. So I'll primarily highlight some of the key focuses for Jardiance. This is the list of patents, so you can see when the drug is expected to come off patent. Scrolling through to utilization. So obviously all the utilization numbers are going to be significantly, important and unique to Jardiance as a whole. You can see that it makes up a pretty substantial, a higher percentage of overall gross spend for this drug. So if you look across the NDCs, it makes up about 2 to 3%, 2.5% of total spending in the commercial space, and this trend is reflected across the different payers. So looking at state and local government, sorry, I keep on bouncing between, state and local government and Medicare, the trends generally hold up. So I would encourage the board to look at table 12 on that, 12B. So then going through to 4.2, change in total gross spend, same trends that you would expect before. Again, just shows trends over time, and gross spend has continued to increase over time, though you can see there are some NDCs where it has decreased over time. Going to 4.3, so this is across the different markets. The impact, excuse me. Same thing as before, we kept all of our analyses to the total prescription drug spend for each of the different markets, and that's reflected in the tables above. Moving on to section 5, pricing information and rebates. Exhibit 1 showed the price increases over time for WAC, AWP, and then publicly you can see NADAC, SAC, and ASP and FSS. Those are reflected in this table here. The net price and sales were redacted as proprietary information for 5.2, but the board will be able to consider those in closed session. We also had the same table for factor 5.3 to show the discount as a percentage of WAC, including the maximum fair price. So that's included in the dossier, though the WAC and percentage are ultimately redacted. Let's see. The RFI submissions contain a lot of the information around price concessions, discounts, and rebates. So the board can consider those in closed session. Going on to 5.5, same thing, information supplied by the manufacturer of any explaining the relationship between pricing of the prescription drug product and then cost of development. So that's all considered by the board in closed session. Going on to 6, so this is therapeutic alternatives, cost comparisons, and health economics and outcomes research. So the WAC and AWP are redacted as confidential proprietary information. The Price concessions, same thing, are available to the board based on a database that provides data to us, and the redacted version is available publicly. Going to 6.3, this is utilization, out-of-pocket costs, and costs for therapeutic alternatives. That's all available in the MCDB. I don't think any of that is redacted. And then in 4, this is a summary of the cost effectiveness analysis. And section 4.5 also includes the comparative effectiveness research. So for both of these, most of this research is done across SGLT2s. So a lot of the research that we already summarized for you is already available. The one thing I would note is that there are some, for the few studies that actually compare across the SGLT2s, Jardiance does have some slight differences that I'm trying to note here. So the one thing to note is that Jardiance may be more cost effective than other SGLT2s for reducing cardiovascular risk for patients with diabetes. And that's compared to Invokana and Farxiga, but not others. So that's just one thing to note, is that Jardiance in particular does have a very special place in therapy for patients with cardiovascular disease and diabetes. Similar, but everything else is comparable to the other cost effectiveness and comparative effectiveness research that we've already gone over. So similar additional benefits in heart failure for folks with diabetes and without diabetes, chronic kidney disease, similar benefits to those with and without, so the subgroup doesn't matter. And then for diabetes, the incremental benefits are more notable for patients with cardiovascular risk, heart failure, and kidney disease. So again, just emphasizing that it's most important for patients with these comorbidities. All right, we are almost through. Let's see. So moving on to, so it doesn't have a generic drug. There are no therapeutically equivalent drugs, again, meaning that there's no generics that are available. In terms of cost sharing, so the similar tables are available. The research is not different. So the medical claims database research had the same general findings. There's very limited impact on the impact based on the data that we researched, and the literature review that we did included the same literature. So that's all the same across the SGLT2s. So nothing new there. The patient-specific drug programs, we noted that there is the Jardiance Savings Card, and this allows patients to pay as little as $10, but we're still not able to identify any publicly disclosed information talking about the general scale or availability of that program. Here's the metrics on average patient co-pays and cost sharing across the different markets. We also included for, here's the average cost share in 7.4. Let's see. And then in 7.5, we go through the mean, median, and 90th percentile for out-of-pocket costs per patients compared to state incomes. The dossier itself lists the state incomes for your reference. And then in 7.6, same literature, so same findings that the board has already been presented with today. And then for 7.7, the costs to the health plans based on the patient access, we can make the same certification that the cost to the healthcare plans or patient access is consistent with FDA labeled indications or standard medical practice. Again, we have a table that basically shows you what it would look like based on clinical evidence. So all the utilization data that you reviewed is consistent with that, so that we can certify that as part of our work. We are now on to Section 8, and the board has before it the different public comments from all the different public comment periods. Again, very much appreciate the public comment from stakeholders providing that to the board. We did not identify any state, federal, regulatory, or compliance issues that are specific to this drug. In 8.3, we did not receive any specific input from state and local government entities, though we will continue for future cost reviews to engage our public sector partners. And then we also have the RFI documents that are available here. Great. So much quicker review. Again, a lot of class-wide work that we've done up to this point, but did try to highlight the key differences for Jardians.
Great. Thank you very much, Andy. And thanks for y'all's work. Certainly appreciated by all. Any?
Mr. Chair?
Yes.
I believe your attorney made a typographical error in the resolution that I need some clarification from Dr. Anderson from. It was for the third item that you, circumstance that you identified in the public session. Total gross spending for Farxiga for certain markets, but I understood it to be the state and local government exceeds 1% of total prescription drug costs. Is that for the state and local governments or for the state overall?
For each market is prescription
For
drug
each
costs.
market except for Medicaid.
Okay,
The spend.
Yeah, of the prescription drugs.
Of the spend except for Medicaid.
for each market. Okay, let me make that correction. Because I think I had said for the state rather than each state market, so let me make that correction. Okay,
We don't need to vote on that?
yeah,
We do need to vote on that?
yeah, you do.
So we've got an amendment.
A correct, yeah,
A
correction.
correction to the resolution.
Correct. It is on the second page. The third circumstance should read, total gross spending for Farxiga for certain markets, especially state and local governments, exceeds 1% of total prescription drug spend for each market, parentheses, public session. Is that correct?
That's correct.
Yep.
No. No, it doesn't exceed 1% in each market,
It does.
right?
It's, the 1% is fine, but it's a proportion of total gross spend, not of prescription drug spend,
Of gross prescription drug spend.
right? It's the gross spend.
Yeah.
Yeah,
Yeah.
on prescription.
Yeah.
Wait a minute. Gross prescription drug spend.
Yeah, sorry, we're pulling.
So
up
if they
the
spend,
table.
if they
Market.
spend 300 million, it's 3 million.
Yeah.
Okay.
Okay,
It's
let me,
1.1
let's try
specifically.
again, just, but the issue was, we misidentified the 1% of the state spend as opposed to the 1% of each of the, I guess, markets or payors. So it now reads, total gross spending for Farxiga for certain markets, especially state and local governments, exceeds 1% of gross prescription drug spend.
Done.
Period.
But
For each
whom?
market.
For each market.
Yeah.
Is that correct?
Yeah,
No.
except for Medicaid.
So Van's example is correct. If the spend for the state employee health plan is 300 million, then $3 million is 1% of that spend, whatever that represents.
Because it was less than 1% for Medicaid.
That's what
Correct.
I said.
Sir,
Shouldn't say for each one, state and local.
Right.
If you just stick with state and local, you're fine.
Exactly.
Okay, for state and local governments, exceeds 1% of gross prescription drug spend for state and local governments.
Well, you're saying it twice, but that, I would just put a period.
Yeah.
Okay,
Okay, you need to vote on that.
there's a motion. I just made a motion. Jerry seconded. All those in favor?
Aye.
Opposed? Are you clear, counsel?
Total gross spending for Farxiga for state and local governments exceeds
Okay.
1% of prescription drug spend for state and local
right.
governments. Correction made. You have,
We're done.
You are done.
I'm now going to entertain a motion to close this, to go to closed session.
Before you do that, can you take a moment of personal privilege?
No. I've always wanted to do that. I never did it, but I always wanted to do it as chair.
I think it's the first time it's happened to me, Mr. Chair.
Yes,
Thank
Delegate
you.
Cullis.
Thank you for the levity. And this board exists because we were watching the cost of prescription drugs just escalate at a tremendous rate. It is now up to 1/3 of every premium dollar is going towards prescription drugs. And so we had to get a handle on on that pricing and how we could perhaps take a look at how it works. And that has always been sort of the black hole in terms of how the process works through all of the different components and elements of the drug pricing chain, and what this board has accomplished and the staff of this board has accomplished is to try to bring light to all of the possible data to in this chain to make a determination that whether or not the cost is that the residents of Maryland are getting the best benefit out of their prescription drugs and what they're paying for them. So I just want to say with the most sincere thanks to you and your staff for bringing this to light and taking this first step. I know it's been an arduous process, but it was arduous simply because you gave every opportunity to every possible stakeholder to be engaged in this process. No one can say that this process was not transparent. And I will stand up to anyone who challenges that notion, because with your opportunities for public comment, your opportunities from the Stakeholder Advisory Committee, you have the information from the folks who are most affected by these prices, both on the production side and on the utilization side, than I have ever seen in any kind of operation. So please know that I honor your diligence, the hard work, and I look forward to continued meetings. And I won't be able to stay until after this closed session, but I will be listening. So thank you again for your time, your energy, and your attention to this very important issue for all residents of Maryland. Thank you.
Well, on behalf of the board and staff, thank you very much for your continued involvement and interest. It helps us get through these days like this and these times. I said earlier today that because we get a lot of negative feedback on how we are perceived and what we've done, what we haven't done. And I said I sat in deregulation in the last 2 days of session, probably 15, 20 years ago. And if if they don't think this is transparent, they should have been around for deregulation in the electric, because there was no transparency to that. And I do think this board and staff have tried over the last 4 or 5 years to be transparent and to put everything out there. And to Andy and they've consistently said, we need to do this. We need to put it out there. We need to bring the public in. So we've tried, and I know we can't please everybody, but again, thank you for your involvement. Appreciate it.
Thank you.
All right. With that, that might be the last time I recognize. Just kidding. So now I'm going to entertain a motion to go into closed session to review and discuss proprietary, trade secret, and confidentiality information concerning Jardiance under general provision of 3-305B13 and Health General 21-2C03 and 21-2C10. Also to receive legal advice, which we so desperately need, from counsel regarding the cost review study and maintain confidentiality and attorney-client privilege in closed session under the general provisions of 3-305B7. Is there a motion?
So moved.
Moved by Jerry, second.
Second.
Second by Joe. We are going to close session. We'd love to see your smiling faces when we get back, but we understand if you're gone. There are other things other than Maryland PDAB. Okay, we're going to bring the public meeting back to order. Thank everyone for staying. As last time, the board considered a lot of different information that was submitted by various entities through the RFI, as well as other proprietary pricing data obtained through licensing and data use agreements with third parties. The board endeavors to be as transparent as possible with its obligation to protect the confidentiality and non-public confrontational data and information. We did consider several things. So with that, I'm going to open it to the floor. We'll have a similar scenario. Michelle will work on a resolution as we go through our conversation, and we'll adopt a resolution at the end of the process. So let me start with Joe, down on that end, see what he has to say.
Sure. So for Jardiance, I think, yes, I'm sorry. For Jardiance, I think a specific affordability concern, again, is the out-of-pocket cost that different individuals are facing in the state. Depending on the payer themselves, from the public information in Factor 7.5, depending on which NDC is being used, at the 90th percentile of out-of-pocket cost, we're seeing, spending $400, $500, $600, or over $1,000 per year. And our discussion using the proprietary information in closed session considered sort of the high amount that some individuals are paying relative to the fully rebated amount that many payers are actually paying to acquire this drug. So I think our specific item is sort of disproportionately the impact on patients, some patients, is certainly at the high percentiles of out-of-pocket cost relative to the net cost that many payers are paying.
And let me just clean this up once again. The board met in closed session as a result of the in consideration of the proprietary and confidential data that the board considered. The board voted and found a preliminary affordability challenge based on the circumstances just articulated by Dr. Levy, that at the 90th percentile, patient out-of-pocket costs in certain markets is disproportionate to the net cost paid by payors, again, that being confidential proprietary information.
Yeah. Yes.
There was also a second finding, a second set of circumstances.
That I'm awake. We have the confidential data on the WAC and how it's increased over time from when the drug became first available in 2014, and we note that the WAC price, the list price of the drug, is substantially increasing faster than the rate of inflation.
And the board considered these items and voted on these items and found a preliminary affordability challenge based on those two circumstances, and has, as the chair has suggested, asked me to draft a resolution so that the board can then ratify those findings in open session. And then, Mr. Chairman, it would be up to you to engage the board in any discussions of public-facing data.
Correct. So we'll go with that. Barry, start with you.
Okay. Thank you. In terms of the public-facing data, what stood out for me was the information that was provided under the factors 4.1 through, I think, 4.4, utilization of the drug product under review, looking at Jardiance, and particularly as the spending on Jardiance pertains to the overall drug spend. So spending on Jardiance represents over 1.8% of the overall total prescription drug spend for both the 10 milligram and 25 milligram strengths. And that is focusing specifically on the state and local government, which I believe would create an affordability challenge, not even considering the commercial, which was consistently higher across both strengths.
Is that the total gross spending for Jardiance for state and local governments exceeds 2% of gross prescription drug spend for state and local governments? Is that correct?
1.8%.
1.8.
Exceeds 1.8%.
I was rounding.
Yeah, that's fair.
Okay.
You good there? Stephen?
Again, I just want to reiterate that nowhere are we saying that, either of these drugs are bad drugs. These are very effective drugs in the treatment of diabetes and its complications, much better than the cheaper, older drugs. We're just trying to hold down the spending overall.
Jerry?
I'm done.
Done? Joe?
Yeah, maybe just building off Stephen's point, these two drugs are actually competitors for many different indications. And I think it is, it was again notable that the comparative effectiveness of this drug relative to alternatives was pretty good. And that we absolutely, do not want to be doing things to hinder access to these two drugs in the state of Maryland. And that the board, I think, is taking and needs to take very seriously that we don't want to adversely impact access to patients to acquire these drugs in the state of Maryland because they're good drugs. I think there were some interesting things that the board might investigate further in the future based on, oh no, I can't talk about that, so I'm not going to talk about that. But overall, high efficacy for these drugs relative to alternatives, and again, sort of the need to examine the price of alternatives, I don't think was really necessary, given what we saw, strong comparative and, generally pretty cost-effective examples of the studies that we reviewed for Jardiance. One maybe larger point that I wanted to make for the board staff, and I know there were sort of strictures on how things were put together. I did find some of the way the information was presented in the dossier to be a little challenging to parse. A couple times we've said, like, was this an apples to apples comparison? And I think the reporting at the NDC level has made that particularly challenging. And I would sort of encourage us as a group to come up with a way to kind of consolidate all of these different NDC codes that have different strengths and quantity amounts and all of these things, and sort of consolidate them into, the most likely or maybe the weighted average dose that a group is going to use over a particular period of time. And I think that would really make this cognitive process of kind of reviewing this information quite a bit easier. Maybe this is not the right time for that discussion, but I wanted that in the record.
That's a good point.
If we're looking for additional information that would be nice to have, one is this level of state spending over time for Jardiance and Farxiga, from 2014 to the present. What has been the increase in state spending for these two drugs would be important. And then something I raised in the meeting is the difference in between the SAAC price and the Medicare negotiated price, and understanding the differences between those and what's behind them.
And I've gotten my nerve back because I'm not going to say proprietary information, but I think one of the things the board, was attempting to look at was copay programs, and we sort of concluded that there was not reasonable amounts of public information that we could really say things about copay programs for these drugs. And I think I would encourage us to continue to work on that and sort of find a way that we could better assess how copay programs are being used in the state of Maryland. We received some information about that in sort of these confidential correspondence. And I would sort of encourage us to study what we were able to find out about those programs in the drugs that we were looking at.
Did you have something else about?
Oh, yeah, just a couple of points here is specific to this Jardian's discussion is same as previously noted around benefit design. We had this factor 7.1 where our analysis showed, at least for one of those metrics, coinsurance, I believe, a negative relationship with the prescription drug use claims, which would be counter to what's been published in the literature. And in fact, we cited some of that literature. Part of it could be our choice of how we chose to model this out in terms of using continuous variables or other analytic decisions, but it is something I feel we can, we had a slide drawing conclusions. I feel like we can maybe just recognize these are still unadjusted results even in our analyses, and so we shouldn't yet conclude on magnitude of impact until we do some additional analyses. I just wanted to kind of share that. And then also, as we kind of are thinking about utilization, saw the lower utilization in Medicaid population, thinking about that percentage contribution to total prescription drug spend. If it was around 1%, a little under for the others, it was 0.4%, 0.5% for Medicaid.
Very good. Anybody else? Andy, you have anything? Are we ready, Michelle?
Yes.
For you to read the?
Well, it's ready for you if you'd like to.
Well, I thought you were reading it just like last time.
Well, I can do that.
To be consistent. You always like to be consistent. Just saying.
Consistency is the hobgoblin of little minds.
Foolish consistency, that's the actual term.
Resolution 2025-02, and let me make that correction at the top. Changed it from 2501 to 2502. Of the Prescription Drug Affordability Board Preliminary Determination Cost Review Study of Jardiance, July 28th, 2025, whereas the Prescription Drug Affordability Board is authorized to conduct a cost review study of selected prescription drug products, and whereas the board selected Jardiance for study, and whereas the board has considered the data, analyses, and information assembled by staff in the dossier, organized in part by regulatory factor, and whereas the board has considered the public, oral, and written comments received to date as part of the cost review process, and whereas the board considered, discussed, and deliberated concerning the proprietary, trade secret, and confidential information and data in closed session, and whereas the board may preliminarily determine whether use of the prescription drug product has led to an affordability challenge to the state healthcare system or high out-of-pocket costs for patients, and whereas the board may identify the circumstances under which the prescription drug product has or will lead to an affordability challenge to the state healthcare system or high out-of-pocket costs to patients, and whereas upon consideration and deliberation of the proprietary, trade secret, and confidential information in closed session, the board voted to make a preliminary determination and identified two circumstances relying on confidential and proprietary data under which the prescription drug product has led to an affordability challenge. And whereas the board hereby ratifies the closed session vote determination and the identified circumstances as set forth below, it is hereby resolved that the board makes a preliminary determination that use of Jardiance has created an affordability challenge for the state healthcare system, and that the use creating the affordability challenge was consistent with the labeling approved by the FDA or standard medical practice. The circumstances under which the prescription drug product has led to an affordability challenge include: 1, the percentage change in WAC over time is substantially larger than the percentage change in inflation, parentheses, rate of increase in inflation. That was from the closed session. 2, at the 90th percentile, patient out-of-pocket cost in certain markets is disproportionate to the net cost paid by payers. That was also in the closed session. And 3, total gross spending for Jardiance for state and local governments exceeds 1.8% of gross prescription drug spending for state and local governments. And that was in the public session. Be it further resolved that in accordance with COMAR 1401-0405F2, the board's preliminary determination is non-final and subject to revision and modification, and any circumstance is a sufficient and independent basis for the preliminary affordability challenge determination. Be it further resolved that the executive director and staff are authorized, directed, and empowered to draft a cost review study report in accordance with this resolution and the regulations to be published as a draft for public comment, subject to a final determination and approval of a final report. And then there is a certification for the chair.
Great, thank you, Michelle. I'm going to make a motion that we approve the resolution. Is there a second?
Second.
Stephen. We'll do a roll call again. First of all, any discussion or comments? Hearing none. Stephen?
Aye.
Barry?
Aye.
Joe?
Aye.
Jerry?
Aye.
Chair votes in the affirmative. Am I signing this one, Michelle? And you're going to redo the front to change it from 1 to 2?
Just cross that out.
I did that.
Okay.
I'm
I
happy.
will-
That's
I will-
how I would normally work, but I know you prefer something else. So.
I like them pretty, yes. I will make that technical correction.
Okay. You good, counsel?
Yes.
Let me give a big thank you to our DLS staff. As always, wonderful job. I appreciate you staying and hanging in there with us. Andy, to you and to everybody, job well done, a lot of work, shorthanded, but we appreciate all the effort that you put forth. To the board, thanks for all the work that you've done over the last couple of weeks with the dossier and the review over the weekends. I appreciate the time and the effort put in. So thank you very much. I'll entertain a motion for adjournment.
So moved?
Moved. Second. We stand adjourned until the September 20.
Are we gonna have anything in August?
I think we might have an August.
Were we gonna have a,
I'm sorry? September 15th.
we were gonna have an ad hoc meeting in August?
August?
No, because September's 2 weeks earlier,
Okay.
because we moved from a holiday. So as of right now, it's September 15th, and they got a lot of work to do in between. So if something pops up, we'll do it if it's worthwhile.
That's fine.
Okay? If not, September 15th. Thank you.
Thank you.